So now let's go to the specific drugs or anesthetic agents under general anesthesia. So when we talk about general anesthesia, we can classify or categorize them into inhalational agents and parenteral agents. For inhalational agents, we have the volatile anesthetics and we have the gaseous anesthetics. So for volatile anesthetics, we're going to talk about isoflurane, sevoflurane, desflurane, halothane, and enflurane. For the gaseous anesthetics, we're going to talk about nitrous oxide and xenon only. So for the parenteral general anesthesia, we will be talking about propofol, the barbiturates, etomidate, ketamine, and the different anesthetic adjuncts. So let's start with the inhalational anesthetic agents. We have the volatile anesthetics. So the first is isoflurane. So isoflurane is typically used for maintenance of anesthesia after induction with other agents. This is because of its pungent odor. It produces a concentration-dependent decrease in arterial blood pressure, but the cardiac output is well maintained. So hypotension is the result of decreased systemic vascular resistance. Isoflurane also produces concentration-dependent depression of ventilation, and it causes bronchodilation. It's a bronchodilator. However, it is also an airway irritant and can stimulate airway reflexes during induction of anesthesia. So it produces coughing and laryngospasm. So these are some things that the anesthesiologist using isoflurane has to consider in a patient. So this is your isoflurane liquid for inhalation. It is placed in the anesthesia machine and given to the patient through inhalation. We also have sevoflurane. So sevoflurane is widely used for outpatient anesthesia because of its rapid recovery profile and because it is not irritating to the airway, even if it is a potent bronchodilator. So it produces concentration-dependent decrease in arterial blood pressure due to the systemic vasodilation, and it also causes decreased cardiac output. However, it does not produce tachycardia, so that's why it may be the preferable agent in patients who are prone to myocardial ischemia. This is your sevoflurane. It is also in liquid form and given to the patient through inhalation. We also have desflurane. Desflurane is used for outpatient surgery because of its rapid onset and rapid recovery time. However, it irritates the tracheobronchial tree and can provoke coughing, salivation, and bronchospasm. That's why it's usually induced with an IV agent. Also, its emergence is rapid, so that's why it's also being used for outpatient surgery because of the rapid emergence after the surgical operation. And it also produces hypotension primarily by decreasing systemic vascular resistance, just like the previous agents. So this is your desflurane. Just like the previous drugs, it is also in liquid form and given to the patient through inhalation. We also have halothane. Halothane is used for maintenance anesthesia. However, halothane causes hepatotoxicity. That's why its use is limited. So it can produce fulminant hepatic necrosis or halothane hepatitis in patients given this drug. Halothane hepatitis causes fever, anorexia, nausea, vomiting, and has a fatality rate of 50% a few to several hours after use of halothane. So this is halothane. So it is also in liquid form and given through inhalation. And lastly, enflurane is used for the maintenance. It's also for maintenance of anesthesia. But its use is limited also because of nephrotoxicity. So it causes a decrease in BP, which is the result of vasodilation and depression of myocardial contractility. And it can produce seizures and should not be used in patients with seizure disorders. This is enflurane. So by the way, this is how your anesthesia machine looks like. So actually, the anesthesia machine is only this part. Here below, these are drawers where you can place medications and other equipment. And this one is your cardiac monitor for the monitoring of the patient. These are the bellows that are attached to the anesthesia machine. So this will be used to bag the patient. Much like an ambu bag or a bag mask device. But the tubes are connected to the anesthesia machine here. And these are the knobs that control how much gases are given to the patient for inhalation. So the liquid medications are actually placed here where they are aerosolized and given to the patient to inhale. If you notice, there are color coding schemes. Purple is for isoflurane and yellow is for sevoflurane. Now at the back of the anesthesia machine, you will find a lot more tubings and usually you will find the gas tanks. The tanks are usually color-coded for the gases that they contain. For example, oxygen is usually in a green tank. So let's now proceed to the gaseous agents. The first is nitrous oxide. It's one of the oldest. So nitrous oxide is a weak anesthetic that has significant analgesic effects. Surgical anesthesia is only achieved under hyperbaric conditions. A major problem with nitrous oxide is that it will exchange with N2 in any air-containing cavity in the body. So this increases the volume or pressure in the cavity that it escaped from. So for example, a patient has a pneumothorax or an obstruction in the middle ear or an embolus, an air embolus, or a loop of bowel that is obstructed, or even intracranial air. So these are examples of air collections that can be expanded by nitrous oxide. So the use of nitrous oxide should be avoided in these clinical settings. The clinical use of nitrous oxide is controversial due to the potential metabolic effects related to increased homocysteine and changes in DNA and protein synthesis. So that's why it was a relief that the fluorinated hydrocarbons or the fluorinated inhaled anesthetics were discovered or developed. Another gas used as anesthetic is xenon. However, it's a very rare gas that cannot be manufactured and it must be extracted from air. That's why it is very expensive. So this limits the use of xenon. It also has, sayang lang because it has minimal cardiorespiratory side effects. Now, the analgesic and anesthetic effects are due to non-competitive antagonism of the NMDA receptor and agonism at the TREC channel. So the TREC channel is a member of the 2,4 potassium channel family that we talked about earlier. So these are thought to be the central mechanisms of action of xenon.